Good morning and good afternoon and good evening, all of the members who are joining from different parts of the world. We are so excited for this Monday's VMR. We have subspecialty VMR, and it's going to be gastroenterology and hepatology VMR. And we are fortunate to have with us Dr. Wang, who I'm sure so many of you know, because if you listen to the Curbsiders podcast, there are multiple episodes on like irritable bowel syndrome, on constipation, on diarrhea, which Dr. Wang has been featured on, and amazing teaching. And like I can introduce her a little bit and then I will ask her to also share a few words about what she likes in GI. So she completed her residency in the Emory and then she went to Mayo Clinic for fellowship, and then she stayed there as a faculty member at Mayo Clinic, Rochester, Minnesota. And she has a big name in teaching as well. So like she was recently even awarded the best student and best teacher award in the outpatient teaching. So we are so lucky to have her with us. And I'm sure we will learn a lot about GI and hepatology today. So Dr. Wang, tell us a little bit more about what you like in GI, what are your interests outside of medicine, and then maybe you can pass the mic to Caroline and Jean.
Absolutely. Thank you so much for having me and for such a generous introduction. Um, what I love most about GI, I think there's nothing I don't really love about GI. I guess the liver is not my favorite thing, but I still love it anyways. Um, I think what I love most about GI is the kind of breadth of what I get to do in the varied clinical settings. You know, we get to do clinical thinking and problem solving, but we also get to work with our hands and do procedures. We get to be inpatient, we get to be outpatient, and really see patients at all spectrums. And I think one of the most unique things about GI that often people don't think about is we get to practice well people care. We get to practice preventative care. And being able to take someone who is healthy and coming in for this colonoscopy and potentially change the trajectory of their lives, you know, preventing a colon cancer, or just clearing them of polyps is something that's unique to our specialty or subspecialty and really brings a lot of joy. So I really love that. Outside of medicine, I like to bake, I like to eat, and I like to find good places to eat. I'm proud to be Yelp Elite for the second year. I'm probably more proud of that than most other things, but I think it's sort of my passion in life. So I'm so happy that I have one of my fellows joining me today, Dr. Caroline Matchett. Caroline was a internal medicine residency here at Mayo Clinic Rochester and is now one of our stellar general GI fellows, and I'll let her introduce herself as well.
Well, perfect. Well, hi, everyone. Like Dr. Wang said, I'm Caroline Matchett. I'm a second-year GI fellow at Mayo Clinic, and I have a passion for medical education, clinical reasoning, and my area within GI of interest is GI neoplasia. I'm completely biased, along with Dr. Wang, about my belief that GI is the best medical specialty, and I think it's because it offers such a unique blend of complex physiology, and I just echo everything that Dr. Wang just said. I'm so excited to be here today to present alongside Dr. Wang and for an engaging discussion.
Perfect. And finally, our case presenter, Dr. Jin, tell us a little bit about how do you come across the GI?
Yeah, hi everyone. My name is Franco Jin. I'm one of the PGY1 residents at Mayo Internal Medicine. I first came across GI during my third year. It was my first week of internal medicine rotation, and I was assigned to none other than Dr. Wang for my GI elective for just a week. And she made such a huge impression on me. She was just the most inspiring teacher, inspiring clinician. I learned so much that week and couldn't get enough. I shadowed her at clinic after, and I just felt in place in GI. So hopefully applying for GI in 1 year.
Perfect. That's amazing. Wow, I can't believe just 1 week and you become a big fan of GI. I am sure that this next hour is going to be exciting. So thank you so much, everybody, for joining. And yes, Franco, let's start. Whenever you are ready, you can present the first aliquot and we will start the screen sharing.
Okay, so here, yeah, so for our first aliquot, we have a patient. This is a 33-year-old patient that's coming into the GI clinic. He recently had a viral infection, or he recently had an episode of diarrhea, and it was presumed viral. And following that, he has just had this ongoing sense of rectal urgency. There on physical exam, there's tenesmus. He reports this sensation of incomplete evacuation. And so for now, there's my first aliquot.
Perfect. Thank you so much, Franco. So maybe I can start with Dr. Wang, that what are the general ways in which you approached diarrhea and what are the key differentiating features?
And am I allowed to ask the audience questions, or am I just supposed to talk?
No, Dr. Wang, you can just focus on discussion. You don't worry about the chat. I will take care of that.
Sounds good. Well, I think it's really always very important for us to understand, what does tenesmus mean and what does rectal urgency mean? And particularly in GI, when we're taking such histories, right, the definition of even something as simple as diarrhea, I actually spend some time clarifying with the patient. And so I really want to know, I guess people can answer in the chat, like, what do you guys think about when you think about tenesmus? And what is tenesmus and what is rectal urgency? And what is diarrhea, for that matter?
Sure, friends, you can answer in the chat and then Dr. Wang will highlight your voice.
I'm going to turn it over to Dr. Matchett here to kind of get her thoughts about what she thinks about and what folks are saying in the chat about incomplete evacuation. Oh, painful defecation. That's a really interesting point too that we can definitely talk about.
Yeah, I mean, that sounds good. And then to kind of launch in or to the side of diarrhea, oftentimes I think about, first question is the patient truly having diarrhea, right? So that bowel movements and bowel habits are defined in so many different ways. And so to have diarrhea, we're doctors, we like to quantify everything. But is having, 3 bowel movements a day or over, 200 grams of stool per day. So are they truly having that is always my first question that I think about. And then, of course, I also think about is what is the chronicity of this? That's kind of my next line of thinking. So is this an acute diarrhea, meaning less than 4 weeks, or is this a chronic process, something that's been going on a lot longer?
Yeah, I love that. And I think someone kind of mentioned in the chat that tenesmus is this feeling or urge to void frequently. Tenesmus is this feeling that you need to go, and then nothing really comes out. Or there can be passage of mucus, and that can still count as a definition of tenesmus. And when we think about that, we think about the various things on our differential that could be triggering our brain to have the need to evacuate, right? And that's a little bit different than rectal urgency, which signals, like the word says, urgency. Like you have to go right now. And if you do not make it to a bathroom, there might be incontinence or a sense of being unable to control that bowel movement. So while they certainly overlap, those terms are a little bit different, right? And often patients have both, but with urgency, usually you produce a bowel movement, whereas tenesmus, you're not really producing anything with that sensation and need to evacuate. And I love that Caroline defined our very structured definition of diarrhea. And often, right, you want to clarify with the patient, is it a voluminous diarrhea? Is it a lot of content being passed, or are they going very, very frequently and they're defining that as diarrhea? But every time they go, maybe there's just tenesmus, maybe there's just a little bit of mucus or even a very small bowel movement, which can actually signal more constipation or a pelvic floor issue, which, some of you may know is like my very favorite topic.
That's perfect, Dr. Wang. Thank you so much for clarifying and laying down the framework that how you define the diarrhea, not just by the volume, but also in terms of frequency and what does diarrhea actually mean. Perfect. Thank you so much. So Franco, maybe you can give us the next piece of data.
Yeah, so So after he comes into your office and you start asking him some clarifying questions. It seems like around 2 weeks ago, he did indeed have what would be classified as diarrhea with just increased frequency, and each of those frequencies, it was just softer stools from his usual. But since then, his diarrhea symptoms have mostly subsided. However, he does feel this dull ache in the rectal area, and it gets worse with sitting, and there's this constant feeling of needing to pass stool, like we mentioned. And so the pain really kind of began after the viral symptoms subsided, and he doesn't have a history of GI disease, and usually has normal bowel movements. And so I guess the next aliquot would be what would be some of the physical exam things that you would try to look for on physical exam?
Perfect. So maybe this time we can ask Dr. Wang that usually when you have the diarrhea and once you have established that this is the diarrhea, how does the context help you? That Franco told us that this happened after a viral illness. So is that something you factor it into, or it could be a red herring? Like, what's your general approach?
Yeah, I love it when patients tell me that something started after a viral illness or some sort of trigger. It gives me a lot to work with, and it's very important for me to think about how things have changed since their initial symptoms. And Franco really carefully gave us this history of how things have kind of altered, but usually patients don't tell us that up front, right? And so I like to ask them, so what happened? What's different between when this first started and what it is now? And it seems like now, maybe even though he was coming in for diarrhea or urgency, there's actually no more diarrhea problem, right? And he's more having an issue with pain, and perhaps urgency. So that's really important for us to think about, is when there is a known trigger, then there becomes a number of things that go on our differential to think about what could be driving this persistent symptom. Or we want to know what has actually happened to him since this diarrhea. Did he try to stop it somehow? Did someone give him something? And maybe I'll let Dr. Matchett speak a little bit to that, to see kind of what do you think about in terms of post-infectious diarrhea, which is how I would categorize this in my brain, if it is truly diarrhea at all at this point.
Yeah, so I mean, the first thing I think about is truly the time course, right? So does it line up with the timing of a viral infection and then, kind of the clinical course thereafter that you would expect? And then I think about, does the symptoms, what he's having, fit with what I would expect from a post-infectious diarrhea? And so he's now having resolved bowel habits. I'm curious, to kind of characterize, like Dr. Wang said, what are his bowel habits like at present, and how have they changed? Because we went from regular bowel movements to what was defined as diarrhea to now having just some rectal urgency, but not really clear on what the bowel habits are at present.
And of course, you want to know, did somebody give this gentleman some antibiotics at some point, right? And I think this has been talked about in previous episodes of CPS as well, this antibiotic-associated diarrhea and how we differentiate that from something like C. diff diarrhea. I don't know if I should expand on that a little bit, or this has been covered already.
No, sure. Dr. Wang, you can expand, definitely.
Yeah, so I think it's important for us to think about, because C. diff is so rampant, right? And know and remember that C. diff can now be a community-acquired infection and does not have to follow a course of antibiotics necessarily, right? It can happen after disruption of the microbiome or just kind of decreased immunity in the setting of some sort of colonization. So the first thing to remember is that C. diff does not always have to follow antibiotic exposure, but on a board exam, it will always follow antibiotic exposure. And then the question becomes, after antibiotic exposure, is this C. diff or is this antibiotic-associated diarrhea? And those two things are actually quite different because they cause different types of diarrhea. So antibiotic-associated diarrhea is an osmotic diarrhea. It happens because of increased bacterial fermentation of your products that you're eating, and causes more development of osmotically active substances in the colon that's going to pull in water and cause stool. Whereas C. diff diarrhea is a secretory diarrhea, and it's going to be because of the C. diff toxin and the irritation to the colon. And so for those that are truly trying to understand, right, is this recurrent C. diff or a C. diff infection at all, and patient needs antibiotics versus patient just needs time to recover after that antibiotic course, you could do stool electrolyte testing to test for that osmotic gap.
That's perfect, Dr. Wang. And before Franco gives us the next data, as he was alluding to, that what would be some of the examination findings that you would be looking for? So maybe Caroline or you can expand upon that. How would that help us to refine our differential?
Yeah, I can start off with that. So first thing I'd want to do pretty thorough abdominal examination to make, and what I'm looking for there is, does the patient have any pain or tenderness anywhere? And, sometimes too, or any abdominal distension for that matter, something that would maybe clue me in to maybe that he's having, more of a larger stool burden now that he's flipped the other way. And then, of course, we're GI clinicians. We're going to do a rectal examination if you come into our office. And that's going to be, I think, really where the gold is here. And doing a really thorough kind of rectal examination to make sure, is there any signs of pelvic, like this, pelvic floor dysfunction? Is the patient having pain on rectal examination? Is there anything that looks like, that there could be some type of infection there? I'm looking for erythema, just general clues.
All right. Yeah, so I'll answer some of the questions that Dr. Matchett and Dr. Wang posed during their physical exam. So the patient does report pain that's closer to the lower pelvic area, localized to the rectal and lower pelvic area. It's a dull ache. It's a pressure, and it worsens when they're sitting, especially at their work as an office clerk. And like we mentioned before, this constant sense of needing to defecate. And when palpated externally during physical exam, there is tenderness over the levator ani muscle. And no other areas of pain or tenderness, such as the abdomen or the lower back. And then some of those rectal exam findings, the sphincter tone is normal. There's no signs of weakness or hypertonicity. There are no masses or abnormalities that can be found on the rectal exam, and there's no evidence of hemorrhoids, blood or fissures on the exam, as one of our chat members mentioned. Yeah, and so I suppose at this time, yeah, I'll let it go to.
Perfect. And Franco, before Dr. Wang or Caroline can expand on physical examination findings, just one quick clarifying question is that in this person's case, like no relevant medications, any family history, social history, or anything that we should be aware of?
Not really. Thank you for reminding me of those. So they take some over-the-counter ibuprofen once in a while, but it's not regular, and some fiber supplementation. And they've always past medical history, no relevant GI history. They used to have pretty regular bowel movements with fiber supplementation.
Perfect. Sure. So, Dr. Wang, now with this information, how does that change what you were thinking before this information was given?
Yeah, so I think that let's take a step back a little bit, because we've been, we started off this case about post-viral diarrhea, and I think it always bears kind of stepping back. Somebody in the chat really asked about, like, how do we differentiate common gastroenteritis versus more severe cases of diarrhea, right? And to some extent, that's a time problem, right? More severe cases of or common gastroenteritis usually is self-limited, is time-limited. And when diarrhea becomes more chronic is when we should become more concerned. Other things are when the stools are excessively watery, or of course, if there's blood in anything, right? That's always a red flag, the color appropriate there. But I think that just because there was a virus that kind of triggered potentially the diarrhea, we don't necessarily rule out other more chronic conditions, right? Especially in a setting where we're talking about tenesmus and pain in the rectum. Somebody in the chat had mentioned proctitis, about hemorrhoids and fissures, and we have to think about IBD, right? Especially in a young man of this age, inflammatory bowel disease with potential proctitis, right? Ulcerative proctitis needs to be on our differential. And this is something that we're going to pay attention to when we're doing a rectal exam. Now, one of the more reassuring features is that he's not having blood in his stools and that the diarrhea has improved. And so those are features that are going to make me less inclined and less concerned about some sort of systemic inflammatory disease or even inflammatory bowel disease. But we do have to keep that in our differential. And in a young gentleman like this, we're going to think about, do we need that mucosal evaluation, which we're going to think about down the line. I have a lot to say about rectal exams, but before I get there, let me see if Dr. Matchett has anything else to add on other parts of this differential and history.
Yeah, no, I was just going to echo kind of what you said. I think it's really easy when you have something like a viral illness that a patient comes in with so clearly and says that first thing off the bat, and then follows that up with, now I've been having diarrhea and some GI symptoms to anchor on that. And as clinicians, you always have to think about, what could I be missing? What else is on the differential? And really kind of starting from scratch. And so not anchoring on that diagnosis. And so I was just kind of a point that I wanted to kind of drive home with all of this.
Yep. And somebody mentioned in the chat about a rectal exam. Would love to talk you through my rectal exam if that is okay with our moderator group. All right. I'm trying to find a schematic that I can use, but I guess you guys are just going to have to let me talk with my hands here. But when I do a rectal exam, so with the bias of I am a motility trained physician, so I do a lot of IBS, I do a lot of pelvic floor exams to look for pelvic floor dysfunction. And so in addition to looking for hemorrhoids, fissures, etc., we're going to go through a little bit how to test the musculature. And I'd love to see a show of hands if anyone knows where the levator ani muscle is and how to elicit pain in the levator ani muscle. Zoom was trying to raise my hand. So
I can say that I did not know this before I met Dr. Wang. So like Franco, met her during my kind of first and second year of internal medicine residency and got the privilege of learning this. And so she's the best teacher for this.
I think the how passionate one can get about a rectal exam can really influence GI applications.
That's right.
But we start out with a general examination, right? And what we are looking for, right, on the outside is a hemorrhoid, a skin tag, and I can say those words, but I have to be honest, I was like a first-year GI consultant before I was really comfortable that I could identify a hemorrhoid. So what are we looking for when we're asking to identify a hemorrhoid? We're looking for soft tissue protrusions, right? It looks like extra tissue, and it's really going to be kind of a vascular appearing. When you think about what a hemorrhoid feels like as opposed to a skin tag, a good rule of thumb is a skin tag feels like you're poking the tip of your nose. So it's a little firmer, a little more almost like cartilage, whereas a hemorrhoid feels like you're poking your lip. I know this is not really like the ideal imagery that we really want here, but that's sort of the texture that you're looking for. With the rectal exam, thank you for the person taking notes here. We want patients in the left lateral decubitus position, and I always have them pull their knees all the way up to their chest. Let me just back up a little bit. We always start off our rectal exam with a good review of what we're about to do. Okay, this is an invasive procedure. This is a potentially trauma-inducing exam, right? And for some of our patients, particularly with pelvic floor dysfunction, they have had trauma in their lives. And so we want to be very sensitive about that. I talk them through the entire rectal exam. I make sure to ask them before I do anything, whether I need to know about trauma history, whether I need to know, and this is a good time to ask those questions. And I make sure to let them know this is your body. If you need to stop, if this is uncomfortable for you in any way, we are done. You say the word, we do not push, okay? I ask them if they want a chaperone, and I make sure to drape them as much as I can so that I'm never exposing more than I have to, right? We want to be very sensitive. And the one thing, if I may kind of deviate a little bit and just share with all of you, that we want to be careful of is our language when we're doing sensitive exams like this. We never want to tell a patient to relax. And we don't want to tell our patients, oh, can you raise your knees for me? Can you lie down for me? Can you relax for me? Those sorts of words are often used in abuse situations to coerce individuals or make them more accepting of a situation. And those are terms that we don't need to use, right? We can't just say, raise your knees. That's all we need to say. We don't need to say, raise your knees for me. Okay, so this is just, if I can send you home, actually with any take home, it would be that. So back to our rectal exam. So we're gonna take a good look at the anal rectum. And what we are actually looking for, right, when we're looking for hemorrhoids and fissures, you're not going to be able to see if you're just kind of lifting and looking. The anal derm is redundant. It's got a lot of folds. And if you're going to find a fissure, which is like a very slim cut, almost like a paper cut in the anal derm, you really have to do a lot of excessive kind of stretching of the anal derm. And so kind of firm pressure and kind of really opening up the area so that you can see between the folds is the best way to make sure that you're not missing a fissure. So we're looking for fissures, we're looking for tears, we're looking for hemorrhoids. And then before I do any sort of digital exam, I'm going to ask the patient just looking to squeeze like they're holding in a bowel movement. And I'm looking for two things. One is, does the anal derm itself move? And so am I seeing the anal sphincter contract, or am I seeing gluteal contraction, which suggests to me that the patient is not able to isolate their anal sphincter, but they're using their gluteal muscles to help augment that motion. This becomes very important if you're looking for kind of fecal incontinence issues. And then I have a patient push out like they're pushing out a bowel movement. Those are the words I use. Hopefully they're clear enough. And when they do that, I'm looking for, is the anal sphincter relaxing? And how far, if any, is the pelvic floor, that perineum, descending away from their belly button? And so it should be pushing downwards at about 1 to 2 centimeters. What does that actually look like? You have to see enough of them and then you're like, this is abnormal, right? You're not actually taking anything to measure 1 to 2 centimeters. But you want to see a slight movement downwards and you want to see slight relaxation of that anal sphincter. After that, we're going to do a rectal exam. And so we're going to put gloves on, we're going to lubricate, and then using that lubrication, we're going to check for an anal wink. So you're just going to take a little bit of cold gel, you're going to tap the anal derm, and you're looking for a reflexive squeeze. When that's not there, a couple of things go through your mind. One, if you're in an acute setting, that's concerning for cauda equina syndrome. But patients like that generally don't walk into outpatient GI. But it is important to think about. And sometimes what I think about is there so much scarring or skin tags or hemorrhoid tissue that patients aren't able to have that sensation anymore. With the rectal exam, as I'm inserting my finger is pointed towards their back, so towards their tailbone. And then I'm inserting at 2 different levels. So one is right at the anal sphincter, right before your fingertip kind of breaks into the perineum, if you will. You're going to palpate and you're going to ask if there is pain at this level, because anal fissures are often on the inside of that anal sphincter tract. And you're not going to be able to see them no matter how well you're looking at the anal derm. And so pushing at that level can identify kind of a deep fissure that you're not able to see. And then as your finger goes higher, you're going to feel this rim of a muscle called the puborectalis muscle that slings around the entire pelvic floor. This is going to be the tailbone on this side or the coccyx. And you're going to push on the back side of this muscle. And you're going to ask them again, do you have pain? This is how you palpate for pelvic tension myalgia. And this is how you're going to exacerbate that elevator ani, which is part of your puborectalis, or the other way around. And see if there's pain at that muscle. That problem of pelvic tension myalgia can cause what's called a frozen pelvic floor, where that muscle is spastic and pulled up so tight or in so much pain that it cannot relax and it cannot let go. We can talk about that a little bit later, but that's why you're checking for that pain. After that, we're going to do that squeeze and push maneuver again. So that squeeze maneuver, I always do at least twice, unless the first time is completely ideal. And then the push maneuver, I'm going to do at least twice, even if the first one is completely ideal. So the squeeze maneuver, what I'm trying to feel is that pupil rectalis muscle where I have my finger is going to pull up and the anal sphincter should squeeze as well. With the push maneuver, you should be feeling as they're trying to evacuate this pupil rectalis muscle relax, and then your finger should come out away from their belly button. Again, 1 to 2 centimeters or so. I've never been able to reliably feel any sort of prolapse, but if it's bad enough, you can feel prolapsing tissue hitting your finger. But you're really looking for that muscle movement to see if it's relaxing enough to get the finger out. If it's not, sometimes again, the pelvic floor is frozen, or you can actually feel what's called paradoxic contraction, where instead of that pupil rectalis relaxing, it's going to pull up even tighter and your finger will pull up towards the patient's belly button. If you pay enough attention, or if you're doing this enough times, what you may also notice is as that's happening at the level of the anal sphincter, the patient's contracting their anterior abdomen to produce enough force that then pushes your finger back out. And so that sort of paradoxic motion can really damage somebody's abdominal wall and gives you a clue as to why they are having problems with their evacuation. Okay, I've said a lot of things. I'm going to stop talking now.
That's perfect, Dr. Wang. Thank you so much for emphasizing that it's not just about imaging studies and fancy labs nowadays. It's also about the core examination skills. And I'm sure that nobody here has heard about such detailed examination ever. So thank you so much for highlighting that. We appreciate it. And maybe, Franco, you can give us now more data, some basic labs or any imaging that you guys did.
Yeah, absolutely. So, just so happened that he also was due for an annual checkup, and so we got probably some more labs than we would need for this focus problem. But for some hematologic labs, we have a white blood count of 7.8 thousand and hemoglobin of 14.3, hematocrit 43.5, and platelets 250. For the serum chemistry, we have a sodium of 139, potassium of 4.2, chloride of 102, bicarb 24, creatinine 0.9, glucose 88, largely normal labs. And because we were, like was previously mentioned, trying to rule out any sort of infectious cause, we did also get a CRP, and that was 1.2. ESR was 8. Because of the ongoing rectal symptoms, we also did get some stool studies, and so generally negative for any bacterial pathogens, no ova or parasites, and fecal occult blood was negative as well.
Perfect. Thank you so much, Franco. Maybe this time I can ask Caroline to speak first. That now that we have these labs and from the ESS CRP, it looks like that it's not inflammatory. So how does that change our differentials?
Yeah, so I think we can get a little bit of reassurance from this, right, and start to narrow down our differential. The first thing I'm looking at is, his hemoglobin. There's no evidence of any type of anemia or that he's losing any kind of blood through his GI tract. And so that makes things like our inflammatory bowel disease a little bit less likely, especially in the context of no elevated inflammatory markers. His white blood cell count is normal, and there's no evidence that he has any ongoing infections. That kind of starts to narrow down our differential even more. And so things that I'm thinking about, is this irritable bowel syndrome? We see this phenomenon of this kind of post-infectious irritable bowel syndrome. But then the other thing, to be truthful, that I'm thinking of is, man, do we need to calculate his osmotic gap? And I'm thinking about that for all of the people who are in here and still in training, and the fecal stool gap that just tends to come up on your internal medicine boards and GI boards. But thinking about, that can really help us narrow down our differential. And so the student osmo gap, of course, if it's less, or not of course, but if it's less than 50, we're thinking of more of a secretory cause. And if it's greater than 50, thinking of more of an osmotic cause, which can also help you kind of clarify or narrow down that differential even further. Dr. Wang, anything else to add to that?
I'll throw out there that that this guy does not have inflammatory bowel disease, but that I cannot be sure of that. And that your ESR CRP, it's important to note that these are systemic inflammatory markers. And that ulcerative colitis is a mucosal disease. And this is a point one of my colleagues likes to drive home on the hospital service. And you can't rule out ulcerative colitis with a systemic inflammatory marker. You actually have to get a fecal calprotectin. And even then, sometimes that doesn't elevate. And so until you have mucosal evaluation, and it's not just GI trying to scope people, but until you have that mucosal evaluation, it's still kind of up in the air whether there could be some mild degree of inflammation at the level of the mucosa that hasn't made it systemic. The fecal calprotectin is a pretty good test for differentiating, though, between IBD and IBS. And so usually if we have both the systemic inflammatory and the fecal inflammatory markers negative, we are pretty certain. But I will agree completely with Dr. Matchett that hemoglobin is 14.3, right? The chance that this gentleman, he's not seeing any blood in the stool. And so the chance that he has some sort of ulcerating inflammatory bowel disease is incredibly low. I don't think I actually answered your initial question. I got a little lost.
Oh no, everything is perfect, Dr. Wang. And maybe now I can ask this, that what are some of the further studies that you would anticipate or you would like to investigate so that we can come closer to the final diagnosis?
Dr. Matchett had asked for an osmotic gap of this stool. And I would actually like to go back and ask the patient, how much diarrhea is he actually having at this point in time? And if you can't get a firm answer from the patient, I would like to send a stool collection and see what is our weight? How many times is he actually going and what's actually coming out? So let's go back and clarify that a little bit. And to answer the chat, a fecal calprotectin would be helpful at this point. Yeah.
Yeah, so we did collect some stool, and it looks like around over 1 day, let's say that this patient had around 75 grams of stool output.
So I'm going to throw this to Dr. Matchett. What do you think about that volume of stool?
Not that impressive. And so I think that really, and correct me if I'm wrong, Dr. Wang, but I think generally the values can range from about 70 to kind of the higher end of more like 300, but anything over kind of 200, 300 grams of stool per day is when we would start thinking, man, that patient really can be classified as having diarrhea. So when I see someone with 75 grams of stool output per day, I'm like, that's normal to kind of the lower end. And I'm right now taking the diarrhea out of the picture.
So then let's go back to, I'm going to throw it back to Franco then. Why is this guy saying that he has diarrhea?
Yeah, so he originally felt it was like it was large volume, and after the viral illness, the volume slowed down, but he does endorse going to the bathroom quite a few times a day.
What does that mean? So how many times a day is he actually going? And I do this with my patients in clinic, right? They're like, oh, I'm going a lot. And I'm like, what does that mean? And they're like, oh, I'm always in the bathroom. I'm like, what does that mean? I need a count, I need a number, and
just to chime in here, this is also a perfect time to throw out the Bristol stool chart and have them point to what their stools look like. Because patients really do have a hard time, one, quantifying their diarrhea, and then also describing it, really like what it looks like. And so it saves a lot of time and effort. You just pull that out and it can be really a helpful tool.
Got it. So first, to answer Dr. Wang's question, this person's heading to the bathroom maybe 20 times a day now, but he tries to go on the bathroom and he's really not coming out with any stool. And Dr. Match's question, let's say that every time he goes to the bathroom and he does have stool output, it's maybe a 3 or a 4 on the Bristol stool chart.
So this is a really interesting kind of clinical scenario, right? He's going like 20 times a day, but only producing 75 grams of stool. And so this kind of changes your differential for what is this truly diarrhea? Or is this more of an urgency issue?
Yeah, it's certainly sounding like the latter to me. You know, it sounds like we're dealing with a 33-year-old, had some diarrhea, now resolved, and now we're dealing with maybe some, you know, certainly some urgency, and then maybe some hypersensitivity or discomfort or pain associated with that.
Sure, Franco, so you can give us more data like the stool osmotic gap if you have, like Dr. Wang asked, and then other mucosal evaluation if you did it.
What was the second part? I'm sorry.
Any mucosal evaluation, as in like scopy or some imaging which you guys did.
Gotcha. And so this person, the scope was normal, and then we also got a gap, and the stool osmotic gap was 65.
So Dr. Wang, can you teach us how to interpret this gap and how does that picture into our clinical presentation?
I'm going to throw this one to Dr. Matchett. How do we interpret that stool osmotic gap of 65?
Yeah, so 65 is a little bit challenging to kind of interpret, I would say, because it falls within that gray zone. I would say that because it's, you know, above 50, I'm less worried about a secretory, you know, kind of process going on here. So I'm more kind of thinking through, okay, is this an osmotic process? Is this, you know, a fatty diarrhea, or is this kind of a functional process? Those are kind of the 3 big categories that I'm thinking of here. And of course, when you think of osmotic diarrheas, we're thinking about, diet, and we're thinking about our ions, our magnesium, and our laxatives, right? And then when we're thinking about our fatty diarrhea, and to just kind of mention that's different than bile acid diarrhea, right? We're thinking about a malabsorptive process here. So within the spectrum of that, you're thinking about your celiac disease, some infections like Giardia and SIBO, and then maldigestive disorders like pancreatic insufficiency. And then for the last bucket, we're thinking about, you know, our functional disorder, which is a kind of umbrella term. But what I would put in there, you know, is our IBS, and then maybe, you know, any type of autonomic, you know, enteropathy that might be going on here. But I will say that, you know, typically I like to see it a little bit higher before I'm saying slam dunk osmotic diarrhea. I will agree that it's a little bit of a gray zone there with that. But that's how I would think through that osmotic gap and the interpretation of it.
Perfect. It's unfair to throw it to Dr. Matchett because really, like, we call this no man's land, right?
Yeah.
Like something between 50 and 100, like we just kind of throw up our hands and say, I don't know. But I will kind of also add that he's only having 75 grams of stool a day. It doesn't matter what his osmotic gap is. He is not having diarrhea, right? And so he's going with frequency. And so we can kind of think about that. But the frequency causing diarrhea, like the stool osms are not going to tell us anything about that, right? The osms are going to tell us what's contributing to the volume of the stool. And so it is an important piece of information, but and we had to kind of get stool in order to quantify that. But with a small stool volume like that, your osmotic gap becomes less relevant, right? When it is relevant, then we go through the exact algorithm that Dr. Matchett gave us to think about, you know, what could be contributing to either a high osmotic gap or a low osmotic gap. With functional diarrhea, it's kind of hard to say what the osmotic gap looks like and kind of it's not as helpful. So I've seen a lot in the chat, and maybe I can just kind of progress the case a little bit since we're kind of hitting on time here in what we're thinking about when we think about this patient. And I will pose that with his rectal urgency and frequency of stools and this tenderness that you're feeling on the rectal exam, that somebody brought out levator ani syndrome, and that is a really good thing to think about. Levator ani syndrome is really defined by your rectal exam. It's that pain on the levator, on palpation of the levator ani, with a good clinical picture that speaks to the syndrome, which often consists of pain and aching in the pelvic floor. And in males particularly, I tend to see diarrhea as a presenting symptom. And this can be exactly what this case is presenting as, which is this urgency that is being called diarrhea. But when patients actually try to go evacuate, there's not actually a lot there. And the reason for that urgency is because the levator ani is irritated. And so it's spasming, and that spasm sends that signal to the brain that there is something to evacuate in this case. A lot of people kind of in the chat are mentioning gynecology exams, right? Bladder, neck pain, prostate exams. And I think all of those are important, and irritation of the pudendal nerve can be important as well. Pudendal nerve irritation tends to be a more neurotic, like a neuropathy type pain, whereas the levator ani pain tends to be more aching in sensation. Women tend to describe it more as a heaviness in the pelvis, or they feel like they're sitting on a tennis ball. And for some reason, men don't tend to have that feeling, whether that's because of differences in anatomy and what's there. Don't quote me on that one, but this is kind of clinical, what we tend to see clinically. But levator ani syndrome is definitely something that's very high on my differential for this gentleman. And for him, it could actually be because of that viral infection, because he was going so often that diarrhea and frequency of stool passage really irritated the levator ani muscle as he's having those frequent stools.
Dr. Wang, I would just kind of be curious to hear your thought process on this too. You know, kind of thinking through cost-conscious care. Did the patient need an endoscopy at this point? You know, before with all the information that we had, you know, I kind of go back and forth because he really didn't have any alarm symptoms, right? We didn't have any rectal bleeding. We weren't having weight loss now or any kind of objective, you know, alarm symptoms. The change in bowel habits, at least temporarily, was concerning, and maybe that in and of itself could warrant, you know, an endoscopy. But I was just curious, at what juncture in this, you know, kind of case would you have pulled the trigger on it? Would you have done it kind of all at once up front, or would you have maybe seen how this trended over the course of the next couple weeks?
I think that's a really good question. I would agree with you that this gentleman does not need a colonoscopy, does not need a sigmoidoscopy or any sort of endoscopic evaluation. He does not need a CT scan. And I think the only thing missing from this case is probably that I would have added is a fecal calprotectin.
Yeah.
And as somebody mentioned in the chat, right, if that's also negative in the setting of kind of no real red flags, no weight loss, you know, this is relatively a short interval and more acute, and he has no systemic markers of inflammation, I would not scope him. That's a really good point.
Perfect. Thank you so much, guys. So Franco, now maybe I would ask you that how was your team thinking at this point in time? What were your differences, and what did you end up doing to diagnose this gentleman?
Yeah, Dr. Wang hit it on the nose. One piece of information that we also collected was an anorectal manometry, and that showed high resting tone, high squeeze, poor relaxation. There was pain at even low levels of balloon distension, and just this inability to evacuate the balloon within 60 seconds. And so given the whole clinical context with this patient, like Dr. Wang said, after a bout of presumed viral diarrhea, and just this more chronic picture of dull ache, especially exacerbated when sitting, and a lack of other lab findings suggestive of another process like anemia or inflammatory markers being elevated, ultimately diagnosed with levator ani syndrome. And a PT is really what we send the patient to.
Perfect. Thank you so much, Franco, for such a brilliant case. And also, I wanted to highlight the fact that we are not even prepared for the case, but you just pulled out this case from your files, and still it ended up being such an educational case, thanks to Dr. Caroline and Dr. Wang. So maybe some departing thoughts, Dr. Wang, that what's this syndrome about? What are some key take-home messages that you want us to remember?
Yeah, I'm going to address one of the points in the chat about Botox for muscle spasm. I think usually we tend to, where available, PT is a better option. It can give longer lasting relief without the potential risk of incontinence with Botox. And so really important to think about PT as your first, like your frontline treatment for these anal rectal diagnoses. Some take-home points from levator ani syndrome, but really like this case overall, right? Verify with your patients and clarify what they mean when they present with specific symptoms, right? This case could have gone a completely different direction if we were just talking about diarrhea in a 33-year-old man, but truly kind of he didn't actually have diarrhea, right? So really clarifying that. And then the other thing I'd like you to take away from this is that your rectal exam and your physical exam in a lot of cases of pain, particularly in the GI system, can be quite diagnostic, right? That anal rectal manometry, when you do enough rectal exams, the anal rectal manometry is really a confirmatory test. If you don't do enough rectal exams, then you can just send for the anal rectal manometry, and that can be enough to make your diagnosis, as Dr. Matchett pointed out, without needing any sort of cross-sectional imaging or invasive testing. And we can really make these diagnoses at the bedside.
Perfect. Thank you so much, Dr. Wang. Caroline, do you have any departing thoughts of how did you find this case? Yeah.
Yeah, I think I'll just kind of drive home the point. History, history, history. You can learn so much by just taking the time with your patients and spending, just a extra couple minutes really trying to understand why it is that they're coming in and why it is that they're coming in at that juncture in time too, right? So that's also important. And I'll echo the physical examination, particularly the rectal examination. You can learn so much, and it can really help to narrow your differential if done well. And I know Dr. Wang, the first time that I learned that, I felt a little bit overwhelmed by all you were teaching me, but you can get it down, and it can be 4 or 5 minutes in clinic, and really will save you a lot of time kind of at the back end, and help your patient out tremendously.
Perfect. Thank you so much. And before we depart, maybe I can ask Dr. Wang one cheeky question. That Dr. Wang, can you tell us more about your book? Like the book and
Yes.
food, please.
That was very kind of you. I'm going to pull it off my shelf here. I wrote a book. It's called Boo Can't Poo. It's about a little ghost named Boo, who goes through some issues with constipation and asks for his family's help in order to figure out how to poo. Pelvic floor dysfunction makes a cameo in the book, as this is a passion of mine. And so, if any of you are looking for baby shower gifts, thank you for the shout out.
Oh my God. I can't believe this. I mean, even at this age, probably this is the first time that I am hearing more about pelvic floor dysfunction, and I can't imagine that young kids, like infants and toddlers, would be knowing about this syndrome before doctors can know. That's so amazing. Thank you so much for that book, Dr. Wang. We will all try to read that book for sure. Yeah. So yes, thank you so much, friends, again for joining on this session. It was a blast. Thanks to Amal for helping with scribing, Kushal for the teaching points, Franco for bringing us a wonderful case, Dr. Wang for emphasizing that how physical examination is key, and all this manometry, endoscopy, and everything could be wisely done and maybe avoided if you do the good examination. And thanks to Caroline also for highlighting the key points about how to approach the diarrhea, tenesmus, and everything. Thank you so much, friend, and we would love to have you next time in the future with another brilliant case, and looking forward to the session. Thank you so much. Have a great week ahead, guys.
Thank you for having us.
Thank you.
Thank you.